everyone, welcome back to my channel. Let us continue our study of endocrine topics. I'm going to revise hyponatremia from Oxford Handbook of Endocrinology. So let's read it. Hyponatremia, actually the incidence of hyponatremia is 15 to 30% of the hospitalized patient and is very common in elderly. I'm seeing these patients quite a lot every day in the ward. It is associated with increased duration of hospital admission and increased mortality. Ambulant patients with hyponatremia have increased risk of fall, fractures, and osteoporosis. Hyponatremia has been associated with increased mortality in all clinical conditions in which it has been studied. So, what would be clinical features you will find in a patient of hyponatremia? Mild hyponatremia may have no symptoms but may be associated with increased falls, more fractures after falls, and osteoporosis. Neurological symptoms are a feature of rapid falls and plasma sodium. Like neurological feature mean the patient can have headache, confusion, seizure. They are very common signs and symptoms of acute hyponatremia. So they are due to rapid fall in plasma sodium. Acute severe hyponatremia developing over less than 48. So hyponatremia is usually classified into two major types. One is acute and other one is chronic. Acute hyponatremia is in less than 48 hours and chronic if it develops over more than 48 hours. So acute severe hyponatremia results in cerebral edema, and when the patient presents with altered consciousness, seizures or coma, this represents a medical emergency which requires urgent intervention to elevate plasma sodium concentration. In such cases, we often treat the patient with hypertonic saline. Then is the chronic hyponatremia. Chronic hyponatremia is more than 48 hours, allows cerebral adaptation with a net shift of organic osmolytes out of brain cells, which allow equilibrium with the serum osmolarity and fewer neurological symptoms. The associated gait disturbance, falls, and fractures still justify therapeutic intervention. So then is the causes of hyponatremia. A number of clinical algorithms are available. The one used in our unit is given here. This is from the Oxford Handbook of Endocrinology. So let us read about this. So hyponatremia is usually classified into hypovolemic, euvolemic, and hypervolemic. So hypovolemic, if the patient is having diarrhea, vomiting, or fluid losses due to any reason, then this is hypovolemic. Also, most of the patients, they are sick and they have poor oral intake. So also consider that even sometimes patient will not have diarrhea, vomiting, but they will have poor oral intake. In such case, you will find urinary sodium less than 30 millimole. And then is the euvolemic. So always whenever a patient will come to you, you will do the basic investigation. Urine sodium is one of the investigation with them. So this classification is based on the urine sodium with the fluid status. So if urine sodium is less than 30 and patient is hypovolemic, the cause is diarrhea or vomiting. If it is more than 30 and patient is hypovolemic, then the cause could be diuretic use. The patient is either on diuretic. Addison disease is also one of the cause, in which there is adrenal insufficiency, aldosterone insufficiency, then mineralocorticoid deficiency, salt wasting neuropathy, and cerebral salt wasting. CSW is cerebral salt wasting. Then is the euvolemic. Euvolemic with urine sodium less than 30 could be due to primary polydipsia, in which patient is drinking a lot of fluids and water, acute water intoxication, malnutrition, or hypothyroidism. So remember, hypothyroidism is one of the important cause of hyponatremia. Then if urine sodium is more than 30, then it is SCE syndrome of inappropriate ADH excretion or glucocorticoid deficiency. And lastly, it is hypervolemic. Hypervolemic with urine sodium less than 30 could be due to heart failure, liver failure, or kidney failure. So liver cirrhosis or nephrotic syndrome in other words. While if urine sodium is more than 30 and patient is hypervolemic, still the same causes: chronic renal failure, heart failure with or without diuretics. So next is the investigation. What essential investigation you will do whenever you will have a patient with hyponatremia? Most important investigation is paired urine and plasma osmolarity. Whenever you are ordering osmolarity, always order them paired, because if you are calculating the plasma osmolarity and at that time urine osmolarity is different, then you will not get accurate results. So always send paired urine and plasma osmolarities. Then send urine sodium, because we know the causes are dependent on that. Then renal function test, thyroid function test, 9 am cortisol. If it is more than 300, usually enough to exclude cortisol deficiency. snack thin test if high diagnostic suspicion. If you are not sure of that, then go for short snack thin test. And then drugs associated with hyponatremia. Always look if the patient is on uh, diuretics or any medication which can cause hyponatremia. Next is the management. Definitive management depend on the underlying cause. Whatever cause you will get, treat the cause. Hypovolemia requires fluid replacement, whereas hypervolemia needs diuretic. So it is very important to examine the patient, to look at the fluid status, to look at other causes of the hyponatremia. Treatment of SCIADA is, we will read about that. Two major guidelines have recently been published outlining acute and chronic management of hyponatremia. The need for urgent treatment with hypertonic saline is determined by the presence of neurological symptoms and not by the severity of hyponatremia. So the risk of inducing osmotic demyelination, this is one of the risk on treating and overcorrecting the hyponatremia. So the risk of osmotic demyelination in asymptomatic patient by rapidly reversing hyponatremia does not justify the use of hypertonic saline. So if a patient is asymptomatic, then you no need to rapidly reverse the hyponatremia, because there is risk of osmotic demyelination with hypertonic saline. However, in patients with acute neurological compromise secondary to hyponatremia, regardless of the duration, treatment with so initially we were saying acute and chronic, but here it is saying that if the patient has acute neurological signs or symptoms, then treat with hypertonic saline regardless of the duration. Recent data suggest improved outcome, particularly neurological, with bolus versus continuous infusion regime. So with bolus there is improved outcome as compared to infusion. Then drugs associated with hyponatremia, this is important. Vasopressin release are action stimulated, like antidepressant like SSRIs, monoamine oxidase inhibitor, tricyclic antidepressants, venlafaxine. Then there are anticonvulsant in the form of carbamazepine, valproate, lamotrigine. Then antipsychotic in the form of phenothiazine, butyrophenones. Anti-cancer drugs in the form of vincalcolides, platinum, melphalan, cyclophosphamide and methotrexate. Also anti-diabetic medication, anti-diabetic drug chlorpropamide. This is anti-diuretic, sorry, not anti-diabetic, this is anti-diuretic. Chlorpropamide and tolbutamide. Others are opioids, interferon, NSAIDs, clofibrat, amiodarone and PPIs also. They cause hyponatremia. Next is how would you manage severe hyponatremia and overcorrection if it occurs. Hyponatremia with associated neurological compromise has a high mortality due to cerebral edema. The aim of emergency treatment is to acutely raise plasma osmolality to cause an osmotic shift of water from brain to the plasma, causing a reduction in intracranial pressure. Patient should be managed in a medical high dependency unit or ICU. So how you will give hypertonic saline? 100 ml of 3% saline should be administered through wide bore cannula over 15 minutes. This is if the patient is having neurological signs and symptoms. Otherwise, we give infusion over 6 hours. So what is the aim of emergency treatment? To acutely raise the plasma osmolality, and in order to decrease the shift of water from brain to plasma, causing reduction in intracranial pressure. So it should be managed in ICU if you are giving 3% in 15 minutes. Repeat plasma sodium should be measured if you have given in 15 minutes, then repeat sodium in 1 hour time. Target plasma sodium in first 6 hours of 4 to 6 millimole. So we should increase the sodium in first 6 hours. Remember 6 by 6, in first 6 hours 6 millimole. The target plasma sodium rise in the first 24 hours should be target plasma sodium should rise in the first 24 hours should be 8 millimole. So in 24 hours 8 millimole, but if you are giving in 15 minutes, then it should be 4 to 6 millimole and no more than 12 millimole in 24 hours. Two further boluses of 100 ml of 3% hypertonic saline if the target plasma sodium has not been reached and neurological features persist. Once neurological symptoms have improved, then no further boluses are advised. Slow correction to a target of 8 millimole over 24 hours can continue. So they are saying that if the neurological features are not improved, you can give 2 further boluses of 100 ml. And once the neurological features are improved and patient is still having hyponatremia, then don't give any bolus. Slow correction to target of 8 millimole over 24 hours can continue. Always be very careful with the overcorrection, particularly when you are giving the third bolus. Patient at risk of osmotic demyelination like alcoholic, malnourished, liver disease should have a plasma sodium target rise of 6 millimole over 24 hours. So if a patient who is at risk of osmotic demyelination like specifically alcoholics, malnourished and the one with liver disease, we should go more slow with a target of 6 millimole over 24 hours instead of 8 to 12 millimole. Closely monitor urine output. Sudden aquaresis can be an elderly indication of rapid elevation in plasma sodium, and an urgent sample for plasma sodium should be checked. If the change in plasma sodium exceeds the target, it should be re-lowered to reduce the risk of developing osmotic demyelination. IV infusion of glucose or subcutaneous desmopressin will help. So, if you have overcorrected the patient by mistake, then you can go ahead with the IV infusion of glucose or subcutaneous desmopressin. So let's read about SCE, syndrome of inappropriate ADH excretion. What is the diagnostic criteria? Diagnostic criteria is the patient will be euvolemic, hypoosmolarity with hyponatremia. When you will check the osmolarity, then plasma osmolarity will be low and the patient will have low sodium. Inappropriate urine concentration more than 100. Elevated urine sodium concentration more than 30 with normal dietary intake. Normal renal, adrenal, and TFTs, and no recent diuretic use in SCE. So, what are the causes of SCE? SCE could be there are multiple different causes, like in malignancy, it could be drug induced, it could be with the respiratory problems, intracranial, and miscellaneous. So, the lung malignancy could be in the lung, nasopharyngeal, pancreatic, GIT, mesothelioma, lymphoma, or sarcoma. With the drugs, it could be SSRI, carbamazepine, the same drugs which were causing hyponatremia. Most of them are same. TCAs, chemotherapy, levotriacetam, haloperidol, and phenothiazine. And then in the respiratory pneumonia can cause this, tuberculosis, vasculitis, abscess in the lung, and positive pressure ventilation can lead to SCE as well. Oh, this is new for me. So, intracranial causes include tumor, subarachnoid hemorrhage, meningitis, encephalitis, vasculitis, subdural hemorrhage. And then lastly, miscellaneous causes are GBS, acute intermittent porphyria, multiple sclerosis, HIV, and idiopathic. What is the management of SCE? Any causative medication should be discontinued if possible. The underlying cause should be treated where possible. Acute, like if it is because of the infection like meningitis, pneumonia, treat the cause. If it is vasculitis, treat with steroids. If it is HIV, treat with the HIV. Beside this, acute severe hyponatremia should be managed as a medical emergency, as we have read previously. Chronic hyponatremia may require drug treatment with an aim to improve plasma sodium level and treat symptoms. So always treat the symptoms, not the number. This is the theory. Several drug treatments have been used for ongoing management, including demeclocycline, oral urea, and V2 receptor antagonist. So this is the one which is most commonly used. There, if we have read, if the patient has been overcorrected for hyponatremia, then give subcutaneous desmopressin. Here, if the patient is SCE, first thing is always in SCE we say fluid restriction to 1 to 1.5 liters. If the patient in a day, in 24 hours, if patient is still not improving, then next thing is treat the underlying cause along with fluid restriction like infection, abscess, chemotherapy if it is related to that. So treat whatever the cause is, and thirdly go for the treatment which is demeclocycline. We mostly give this one. Then fluid restriction remains the first line treatment in most patients with SCE. However, the evidence base is weak. Many patients who fail to have an adequate response or will find it difficult to adhere to fluid restriction limits. Several factors predict the likelihood of failure to respond to fluid restriction, including a baseline urine osmolarity of 500 and a urine output of less than 1.5 liter per 24 hours. So, how we know that the patient is not fluid restricting? If the urine osmolarity is still more than 500, and urine output is less than 1.5 liter per 24 hours. So this is failure of responding to fluid restriction. And then is the V2 receptor antagonist. That 12 veptons. These veptons are also commonly used in practice for SCE. The veptons are V2 receptor antagonists, which competitively bind to the V2 receptors in the kidney, preventing AVP mediated antidiuresis and causing partial nephrogenic diabetes. So there we are conserving more fluids. Here, if we give veptons, they will cause partial nephrogenic diabetes insipidus and will lead to more fluid being removed out of the body. Tolvaptan is a selective V2 receptor antagonist and is available as a tablet for use in euvolemic hyponatremia. So this is one of the tablet we use in SCE. A starting dose of 7.5 mg tolvaptan can be used with a dose titration every 24 to 48 hours if there is inadequate response. The patient should have free access to oral fluids. Plasma sodium is measured every 6 to 8 hours in the first 24 hours to screen for overcorrection. Overcorrection should always be looked for. Overcorrection may occur if the fluid intake is restricted, if baseline plasma sodium is less than 120 millimole. Overcorrection may occur if fluid intake is restricted or if plasma sodium baseline sodium is less than 120. The commonest side effect is polyuria, which I have already said that it induces partial nephrogenic diabetes insipidus. Commonest side effect is polyuria. Liver damage have been reported in patients treated with high doses for polycystic kidney disease. So regular LFTs monitoring is indicated in chronic treatment. So when you are giving veptons, always start with 12 vepton, which is an oral tablet. Start with 7.5 milligram. Measure sodium 6 to 8 hourly in first 24 hours. Make sure that you are not overcorrecting the patient and monitor the liver function test. Then there is demiclocycline. Demiclocycline is a tetracycline antibiotic which has been used second line to manage SCE. So first line we have read that fluid restrict, treat the underlying cause, then go for veptons. Third one is demiclocycline. It is a tetracycline antibiotic which has role as well. It inhibits adenylyl cyclase activation, which occurs after binding to vasopressin to the V2 receptor in the kidney, therefore producing reversible nephrogenic diabetes insipidus. The therapeutic effect is variable and often delayed after starting treatment. Significant side effects may occur, including renal impairment and photosensitive rash. These side effects occur with other tetracycline antibiotics as well. So we need to monitor the renal functions and look for photosensitivity, apply sunblocks and those things. Then is the urea. Urea is also it elevates plasma sodium by increasing water excretion and decreasing urine sodium excretion. Urine containing preparations are poorly tolerated due to taste. There are currently no commercially produced version available. Empagliflozin, which is SGLT2 inhibitor, which we use in diabetes, may be useful by causing inhibition of sodium glucose transporter in the tubule. So empagliflozin is also one. To be very honest, I have never heard of urea being used commercially or in the field for treating SCE. So that's it about the hyponatremia and SCE. I will see you again with another exciting topic. Thank you so much. If you have any questions, please don't forget to ask in the comment section. And if you have not yet subscribed to my channel, please subscribe and keep on watching. And give me suggestions in the comment section if you want to see another interesting video and you want me to discuss the topic. Thank you again. Have a good day.